Hello and welcome to HIT 109. This class is set up with 7 modules. There's 2 lessons in each module with an audio or video lecture. You will notice HIPAA domains listed in the syllabus and in Blackboard. These are for accreditation purposes, and you don't need to know this information. All due dates in this class will be Sunday nights at 11:59 unless otherwise specified. And see the syllabus for my policies regarding assignments, and this is under the heading in the syllabus labeled Assignment Policies. We will meet 4 times on Blackboard Collaborate. These dates are in the syllabus under the heading Class Attendance Policies. These meetings will last less than 1 hour, and it's just an opportunity to check in with each other. The last page of your syllabus is a signature page that acknowledges your understanding of the syllabus and homework policies, and as well as the attendance policies and the expectations of the HIT program. Please sign, date, and upload that document in Module 1 in Blackboard by the end of the first week. So some tips for success for this class. This is a 4 credit hour class. There's a rule of thumb that says for each credit hour, you should spend between 2 and 3 hours of study and homework time. So for this class, that would mean somewhere between 8 to 12 hours of study and homework time. I would also recommend being organized. That could mean different things for different people. At a minimum, I would suggest a calendar. That could be a paper calendar or a digital calendar. Make note of the due dates. Make note of tests. Make note of the Blackboard Collaborate meetings. Take notes, maybe on paper. I really like Microsoft OneNote for taking notes. But maybe you're someone who needs to write things down rather than taking notes online, whatever works for you. And be sure to use the resources in your textbook and in the coding books. And I will point out those resources to you as time goes on. The discussion boards in this course are not mandatory, but they're a really good way to network, to ask questions, and to build community in an online class. So an online class can feel kind of lonely. So I wanted to put these discussion boards in to build that community and build the relationships that you would normally get in an in-person class. So use those discussion boards. So if you're feeling stuck or confused, watch the video another time. Take a break. Sometimes if I'm having trouble with something, if I just take a break, go for a walk, step away from it for a while and come back to it, it'll be clearer. Go to the discussion boards. If you're having trouble with something, chances are someone else is too. I will be on the discussion boards as well. I'll be on the discussion board every day, Monday through Friday. On the weekends, I probably won't be as active on the discussion boards, but you can also email me if you don't want to post your question on the discussion board. But just remember, you're not alone. There's other people out here as well. All right, so let's jump right into the material. So third-party coding or third-party reimbursement. Coding systems are used in the outpatient and inpatient healthcare settings, and each coding system plays a role in reimbursement. So who do you think is the biggest third-party payer in the US? If you guessed Medicare, you would be correct. Your responsibility as a coder is to optimize payment. You're assigning codes so that you present to the payer a complete and accurate picture of the care that was given to the patient. And you're also assuring that the coding data is accurate. Now notice I said optimize. Maximizing or upcoding is never appropriate. So what is upcoding? Upcoding is submitting codes for a more serious diagnosis or procedure than were actually diagnosed or performed. And you might also hear the word unbundling. So unbundling is also inappropriate. That's separately billing for tests or procedures that are normally billed together or bundled to get more money from the payer. Thankfully, I have not come across a lot of ethical issues in my career as a coder. But you need to be aware of some ethical issues that could come up and how to handle those. So some examples of some ethical issues that may present themselves to you would be pressure to upcode a procedure, um, pressure to code a diagnosis based on lab values, which we're not allowed to do, and pressure to code a diagnosis based on the impression or assessment of someone who's not a physician. We can only code diagnoses that are documented by a physician. Our population is changing. The elderly are the fastest growing patient segment. The population over the age of 65 is projected to reach 83.7 million by the year 2050. In 2012, the population over the age of 65 was somewhere around 43.1 million. So you can see it's going to double by 2050. So healthcare is going to need to continue to expand to meet those demands of our growing elderly population. So people are living longer due to technology advances and having improved access to healthcare. So we are going to need more healthcare services, and we're going to need more coders. So you are entering a high demand field. So the Medicare program was established in 1965 with the passage of the Social Security Act. It has two parts, parts A and B. Part A is hospital insurance. Part B is supplemental or non-hospital insurance. And this covers physician services and medical equipment. Part C, sometimes called the Medicare Advantage, this was added later. And prescription D was also added later, and this is for prescription drugs. Medicare coverage is primarily for the elderly, those over 65. In 1972, Medicare added people who were eligible for disability benefits, as well as patients with end-stage renal disease. And people who are covered under Medicare are called beneficiaries. The Department of Health and Human Services administers the Medicare program. And the Medicare program is delegated to Centers for Medicaid and Medicare and Medicaid Services, or CMS. CMS runs Medicare and Medicaid, and they delegate the daily operation to Medicare Administrative Contractors, or MACs. MACs are usually insurance companies that bid for a contract with CMS. So Medicare is funded with money from payroll taxes. The Social Security Administration collects the money from payroll taxes. CMS sends that money to the MACs for the daily operations of Medicare. The MACs handle the paperwork and pay the claims. So the money is flowing from the Social Security Administration to CMS, to the MACs, and then finally to the beneficiaries and providers. So QIO, or Quality Improvement Organizations, are part of the Department of Health and Human Services, and this is their strategy for providing better care and better health at a lower cost. And this is a national network of consumers, physicians, and hospitals, and their work is to improve quality, timing, and cost of care for Medicare patients. There's two types of QIOs. The first one is beneficiary and family-centered care. And as their name suggests, they assist the beneficiaries directly. They review quality of care complaints, and they also review complaints from beneficiaries who have who want appeals for discharges or discontinuation of services. And then there's the Quality Innovation Network, or QIN, and this is a data-driven approach, and they're looking at safety, health quality, and care coordination. All right, so Medicare Part A. Hospitals report services for Part A by using ICD-10 CM codes and a DRG assignment. So we'll cover more about DRG assignment in Chapter 27 at the end of this course. But DRG assignment stands for Medicare Severity Diagnosis Related Groups. And the diagnosis codes influence the DRG assignment. More than 99% of hospital claims are submitted electronically. And like I said, we'll cover this in a lot more detail in Chapter 27, but this is just a very brief introduction to MSDRGs and Medicare Part A. Medicare Part A, you could consider a hospital stay under Medicare Part A as a no frills. They're just going to cover the basics. They cover a semi-private room, which is 2 to 4 beds in a room. They cover meals and special diets while in the hospital, and they cover all medically necessary services. Medicare Part A is not going to pay for anything that they consider not medically necessary. So Medicare Part A is not going to pay for personal convenience items. So this is where Medicare Part B steps in. So Medicare Part B is going to cover the services that are not covered under Part A. So Medicare Part B is not automatic. Beneficiaries have to purchase this separately, and they pay monthly premiums for this coverage. Right now, Medicare Part B is reimbursing at a rate of 80%, which means Medicare beneficiaries are going to be responsible for that other 20% out of pocket if they don't have a secondary insurance coverage. Under Medicare Part B, beneficiaries are going to have an annual deductible, and this deductible changes every year, and the changes go into effect on January 1st. So when you're coding for Medicare Part B, there's 3 coding systems that are used to report Part B. We'll go into Medicare Part B and these coding systems more in HIT 202. But again, just a very brief introduction. You have a CPT code that reports procedures. You have HCPCS codes. Those are also called National Level 2 codes. They report supplies like orthotics, drugs, and hearing aids. And then you also have ICD-10 CM codes. You're going to learn about ICD-10 CM codes in this course. All right, and then we have Medicare Part C and D. Medicare Part C is known as the Medicare Plus Choice Program, and this allows beneficiaries to buy coverage for vision, hearing, and dental. And then Medicare Part D allows beneficiaries to enroll and get prescription drug coverage. They pay a premium and a deductible and a copayment, but then they can get part of their prescription drug coverage under Medicare Part D. The Health Insurance Portability and Accountability Act, or HIPAA, was established in 1996, and the administrative simplification portion of HIPAA was the largest change to healthcare industry ever. And the administrative simplification portion included electronic transactions, privacy, security, and national identifier requirements, or NPI. Providers and payers that are covered by HIPAA are required to submit claims electronically. So the electronic transaction simplifies billing by standardizing the code sets, the billing forms, and rules. So code sets are made up of numbers and letters that identify diagnoses or procedures on claims and encounter forms. So ICD-10 CM codes are the diagnosis codes. ICD-10 PCS are inpatient hospital procedure codes. And as I mentioned a few codes back, HICS, PICS, and CPT are the codes for physician services, medical supplies, and durable medical equipment. So HIPAA requires healthcare providers, health plans, and employers to have National Provider Identification Numbers, or NPI. These are unique identifiers on claim forms that identify providers that perform services. So the NPI database is public and searchable. I've provided the URL here. You can go to that link and you could search your own physician and find their NPI number at that link. The Federal Register is the official publication for all presidential documents, rules and regulations, proposed rules, and notices. The Federal Register publishes changes to Medicare reimbursement. So remember that I said that Medicare is the largest third-party payer in the US. So even small changes in Medicare reimbursement have huge consequences. So the commercial payers like Anthem or Humana, they generally follow what Medicare does. More than half of the patients in a hospital are Medicare patients. So updates for hospitals are in the October edition of the Federal Register. And changes for outpatient facilities and physician fee schedules are in the November and December editions of the Federal Register. So proposed changes come out a few months before, and this gives interested parties times to comment and make changes to the proposed changes, or make suggestions, to the proposed changes. The final rules then are published in October, November, and December. The changes then go into effect in the next calendar year. So thank you for listening, and I will see you in the next lesson.